you. Good afternoon, everyone. I'd like to begin by just very briefly revisiting this study from Gerhard Diller and colleagues. Again, they projected 5-year mortality rates for 40-year-olds with congenital heart disease, and they compared them to the general UK population and learned that a 40-year-old Fontan patient has the same 5-year life expectancy as a 75-year-old of the general population. And my take-home message from this is that many of our complex patients can be considered geriatric, decades younger than their peers. Right now, I'm working with a lovely woman in her 40s who is contemplating going on disability, and we actually talked that in the context of taking early retirement. She said, "I don't know why I'm saving for my retirement in 20 years when I likely won't be there to enjoy it." So we know our patients have a life-shortening health condition. What do they think about this? This is a nice study from Sweden, and they conducted qualitative interviews with 7 patients with Fontans between the ages of 17 and 32, and their analysis revealed 3 main themes: happiness over being me, focusing on possibilities, and being committed to life, which is very consistent with the moving presentation that we began today with from Andrea, the patient who shared her experiences. And one of the sub-themes was living with uncertainty. And the authors concluded that the participants made a pledge to themselves that they would stay alive as long as usual. But all of them knew that they might not have a long life. And here's one moving quotation from a participant: "I don't know much about the future. I don't really think that I'll live until I'm very old. I don't think about it that often, but when someone with a heart defect dies, someone I know, then I'm kind of reminded about death, that it might be my turn next. We're sitting in the same boat, so to speak." This is important to patients. Yuli Kim and the group at Philadelphia surveyed 152 outpatients, and they asked them on a 0 to 10 scale how important it was to discuss advanced care planning with their health provider. And most patients gave it a score of 8 to 10, and what might surprise you is that median scores were actually higher for patients with clinically elevated symptoms of anxiety. So we might think to ourselves, well, these are patients who we ought to shy away from these discussions, but the data does not support that. So we know that this is important to our patients. Well, how are we doing thus far? Well, clearly there's some room for improvement, at least in the outpatient clinic. So along with Daniel Tobler, Matthias Grutman, and Jack Coleman, we surveyed 200 outpatients, and we also surveyed 48 ACHD providers. And of the patients, 78% thought that their providers, their medical team, ought to raise end-of-life issues. They ought to initiate those discussions, and most of them thought that the cardiologist was the provider who ought to do that. In contrast, actually, and I should say that was independent of disease severity, any socio-demographic factors, or health status. But in contrast, we can see that healthcare providers reported that they were more likely to initiate end-of-life discussions with patients with increasing disease complexity. Again, we asked patients and providers, when should we initiate these discussions? 62% of the patients said that they wanted these discussions initiated before getting sick when healthy, so before they were first diagnosed or symptomatic with a life-threatening complication. And yet only 38% of the providers thought that early initiation was important. What else do we know? Well, we know that only 1 to 13% of patients recall previous end-of-life or advanced care planning discussions with their providers. However, 54 to 70% have discussed end-of-life issues with other people. And what this means is that even if patients aren't presenting to your clinic asking about these or talking about these important topics with you, they likely are thinking about them and talking about them with other people. Only 5 to 21% had completed advanced directives, and these are written documents that allow patients to express their preferences for end-of-life treatment should they be unable to speak for themselves. Interestingly, about 2/3 of the patients said that they would want information about the life expectancy of patients with their type of heart condition. Thus, this is an important topic not only for us, but for our patients that we're taking care of. Also, in Toronto, we conducted a retrospective study looking at 48 in-hospital cardiac deaths. Mean age was 37. 60% were in NYHA class 3 or 4. 42% had previously had a heart transplant evaluation. So these were patients, the majority with complex disease, who could be considered in the end stage of their illness. 2/3 died in the ICU, and the median hospital stay was 16%. Well, what were their experiences? So Daniel and Matthias scoured the inpatient and the outpatient notes, and they looked for any documentation of end-of-life discussion defined as conversations about life expectancy, advanced care planning, resuscitation preferences. And they found that such documentation occurred with only 5 patients, 3 before the final admission, 2 during the final admission, and 21 conversations occurred with substitute decision makers. These most often occurred 17 days after admission to hospital and 2 days prior to death, and these discussions typically surrounded things like the futility of further intervention. The palliative care team was involved in about 1 in 5 patients. Interestingly, 25% of the patients in this study died under attempted resuscitation. That dropped to 12% if there were documented end-of-life discussions, and dropped to 0% when there had been a consultation with the palliative care team. So what can we do with our patients with failing Fontans? I think we ought to normalize these end-of-life discussions, explain that we hold them with all patients at this phase of their illness. Schedule a separate visit. Include family members as appropriate. Ask them who they would like at this appointment. Sometimes we're surprised at people that they say they do want or they do not want to have there. Consider the cognitive and developmental ability as well as the cultural background. Document these discussions and these decisions. You can have a great conversation with a patient and feel that you're on the same page, but you may not be the one there on service when they present for inpatient care or they end up in the ER. So it's really important to document what you talked about and what the conclusions were. And standardize your approach to collaborating with palliative care and mental health professionals. When we're talking about prognosis, it can be very helpful to provide a general range. We know you can't give them a date, but let them know whether we're talking about days, weeks, months, or years. You can acknowledge a prognostic uncertainty and consider the term life-shortening medical condition. We know that some patients overestimate and some underestimate life expectancy. Be mindful that many of them will say that they have previously beat the odds. So I'm sure everyone in this room has spoken with many patients who have said, "I hear what you're telling me, doc, but they told my parents I might not live to my first birthday. They told me I might not graduate from high school. Here I am, you just wait, I'm going to prove you all wrong again." And recognize that the balance between being optimistic and realistic can be challenging for patients, families, and providers. So I like this idea of saying that we're hoping for the best and preparing for the worst. Practice routine statements. So I think a 2-stage approach is often helpful. So the first time you introduce or invite this discussion to occur, and then you actually have the conversation at a later visit. At the first meeting, you might say, "Many of our patients have questions about what happens next as they start to experience a decline in their health. Many patients will wonder how long we think they might live and what the next phase of their health care might be like. We think it's important to discuss this as well. Let's plan a special visit to talk about these things." And at that visit where you have the patient and his or her family members or friends, whoever they think ought to be there, these might not be easy things to talk about, but it is very important that we're on the same page. We need to talk about your preferences for end-of-life care and who you want to make decisions about your health if you become unable to do so. We think it's really important to talk about these things in advance. I like the idea of this ask, tell, ask cycle. We first ask what they currently understand, then we tell them information that they want or that we think is vital for them to know, and then ask again to confirm an understanding of what they've said. For example, given your worsening symptoms, what do you think the next phase of your health might be like? Let them answer first, and then you have a good starting point for your discussion. We are at a turning point in your heart disease, and there are choices about which road to take. It is important that I explain things clearly to you. Please tell me what you understood. So in conclusion, improving outcomes for patients with Fontan physiology entails reducing morbidity and mortality, optimizing quality of life, and also providing the highest quality of end-of-life experiences for patients and families. Thank you.